Hi, and welcome back. When we were talking about the endocrine system, we were talking about just kind of a background to all the various types of hormones and a lot about how the chemistry of a specific chemical would affect how it affects the target cell. So, for example, hormones have different chemical makeups, some steroid or lipid soluble based, some protein, peptide, or amine based, which would be more water soluble. And based on those solubilities, they affect how that hormone is able to interact with the target cell and either turn on or turn off a process. So lipid soluble hormones can actually penetrate the target cell's plasma membrane and bind to receptors on the interior and turn on, for example, the production of a protein, whereas the water soluble hormones actually have to interact with a receptor on the plasma membrane surface, which would then activate a G protein. The G protein activates a second messenger like cyclic AMP, diacylglycerol, and inositol triphosphate, which would then bring about some change in that target cell, again, like producing a protein. The next thing we talked about were the fact that the hypothalamus and the pituitary, hypothalamus being an endocrine organ and the pituitary being an endocrine gland, have a really unique relationship in that the hypothalamus is physically attached to the pituitary and attached through capillary portal system, the hypothalamal pituitary portal system, which allows for releasing factors and inhibiting factors, chemicals, to be able to influence the release of chemicals from the anterior pituitary. And that's actually the list that you're looking at right now. On the left, you see all of the releasing factors known as hypophysiotropic hormones. Hypothalamus, entropic because they're going to affect another gland's release. So on the left, you see examples like CRH, TRH, GHRH, which when released by the hypothalamus promotes the release of hormones from the anterior pituitary. For example, CRH affects the release of ACTH. TRH affects the release of TSH, as well as prolactin. Keep in mind that the anterior pituitary's hormones also could be tropic as well, affecting the release of other glands' hormones. And so we're going to continue that topic and make sure that we can understand those pathways. We're now starting objectives 37 through 42, where we're just going to run through all of the different endocrine glands and endocrine organs and see the different types of hormones that they produce and then what the physiological effects are. Let's start with that pituitary gland, which we know has two lobes, has an anterior and a posterior lobe. We also mentioned before that this is called the master endocrine gland because it releases so many different hormones, and those hormones having function relating to growth, reproduction, metabolism, male and female reproductive systems, nourishing and housing an embryo. So many jobs, so that's why it is the master. We also mentioned that it's physically attached to that hypothalamus by way of the infundibulum, and it sits right at the base of the brain within that sella turcica. So taking a look, we mentioned that it's two lobes. There's an anterior and a posterior. So let's try that posterior lobe first, which we also before mentioned that it's called a neurohypophysis, because hypophysis meaning pituitary and neuro being related to the hypothalamus. This particular lobe does not produce any hormones. However, it does store and release hormones that are produced in your hypothalamus. So that's an important distinction. The two hormones that are produced in your hypothalamus are antidiuretic hormone, ADH, and oxytocin. Antidiuretic hormone is exactly what the name would suggest. A diuretic makes you pee, makes you lose water. So it's an anti-diuretic, so it makes you retain water. That's right, it makes you retain water from the urinary system. This helps us to maintain our water balance within the cardiovascular system and peripheral tissues. So if we retain water, this actually reduces the amount of urine that would be lost. So promoting water reabsorption from the really important nephron, which is where all the urine actually is being produced. Another interesting function of ADH, antidiuretic hormone, is vasoconstriction, systemic vasoconstriction. So in fact, if you can retain water and vasoconstrict, both of those functions will actually help to increase your blood pressure. And so very often you may see ADH being released if our blood pressure is low, because this can help to raise it. Another hormone that is produced in the hypothalamus but released by the posterior pituitary is oxytocin. Oxytocin stimulates the contraction of smooth muscle cells in a pregnant uterus, specifically that muscle layer of the uterus called the myometrium. This is necessary during parturition or childbirth. We have to release a large amount of oxytocin to increase the contractions to push out the fetus. Oxytocin is in charge of that pain. Interestingly, oxytocin is also really important for what we call milk letdown. Oxytocin stimulates contraction of smooth muscle in the glands and ducts of the breast, or the lactiferous glands. So the suckling action of the baby stimulates the release of oxytocin. Oxytocin stimulates the contraction of the muscles, which allows milk to literally be ejected from the breast. It's not actually sucked out, it's ejected out through muscular contraction, which sometimes is why when women are breastfeeding, but they're not actually doing it at the time, but they're thinking about their baby, that can actually cause milk release, which can be an embarrassing thing in a grocery store, so they make pads for that. But oxytocin is more of it's a release from the brain, so even thinking about your infant could cause the release. They do actually believe that men can release oxytocin, which would give that kind of male nurturing response to the unborn fetus or to the born fetus. So this is a very busy slide, and I get that, so take a look at it when you've got lots of time. But I wanted to show you the two lobes of the pituitary and its relationship to the hypothalamus. And I also wanted to show you that the posterior pituitary will release antidiuretic hormone, which affects your kidneys, reabsorbing water. It also releases oxytocin, which can affect the smooth muscle of your uterus, as well as ejection of milk or letdown from the mammary glands. We're now going to turn our sights, on the anterior pituitary, this anterior lobe, and you can see all the different hormones and functions that we now have to address. So that anterior pituitary gland, also now called the adenohypophysis, it releases hormones that regulate an entire range of body activities, and we've mentioned that, from growth to reproduction to sexual development, from egg and sperm production, metabolism, so lots of different functions. Most of the hormones that are released from the anterior pituitary are called tropic because they will influence the release of hormones from other endocrine glands, and that's been a topic we've been trying to kind of relate throughout. The release of these hormones is also controlled by the releasing and inhibiting hormones of the hypothalamus. So once again, remember that the hypothalamus will release a releasing hormone like TRH, which would then affect the release of a hormone from the anterior pituitary like TSH, which would then go to the thyroid gland and cause the release of thyroxine from the thyroid gland, which would then thyroxine would go to its target cell and increase your metabolism. That always feeds back to tell TRH what to do. Should I keep releasing? Do you have enough? So there's a feedback loop that's always working. TH, or thyroid hormone, levels would affect TSH, and TSH affects TRH in terms of how much still needs to be released. So again, we have the hypophysiotropic from the hypothalamus, and we have the tropic from the anterior pituitary, and then we ultimately have that endocrine glands and body response. Let's take a look at those anterior pituitary hormones, a couple of them on this slide. The very first one that we wanted to talk about is human growth hormone, or GH. And it does exactly what you imagine growth hormone doing. It makes you grow. It acts on your skeleton, it acts on your body's muscles to increase their rate of growth, to maintain their size, even once you have grown. The effect on bone, for example, would be dependent upon your epiphyseal plate closure. So, for example, growth hormone before epiphyseal plate closure means you're going to get taller. But growth hormone after your epiphyseal plate closure means those bones will either maintain or get wider. They could actually get wider. Did you know bones can get wider and or thicker? The more you use them, the more they respond. So when you work out your muscles, you're not just working out your muscles. You're working out your bones too. If you pull on them, they respond and they get thicker and they get stronger. And that's because of GH release. GH does peak around the end of adolescence. And of course, we do have releasing and inhibiting hormones to control its release. Somatostatin would inhibit, and growth hormone releasing hormone would promote it. We also have thyroid stimulating hormone, or TSH, which we've mentioned a couple of times. TSH, released by the anterior pituitary, stimulates the production and secretion of hormones from your thyroid gland, that butterfly-shaped gland in your neck. This is a classic tropic hormone because all TSH does is stimulate the thyroid to release its hormone, which is called TH. TRH from the hypothalamus to TSH from the anterior pituitary to TH from your thyroid gland. We also have another classic tropic hormone, and that's ACTH, or adrenocorticotropic hormone. This controls the production and secretion of adrenal cortex hormones, most specifically the release of cortisol from the adrenal cortex, which is that small triangular gland just sitting on top of your kidney. Again, it is controlled by the release of releasing factors of the hypothalamus, so CRH to ACTH to cortisol. Again, controlled by negative feedback to keep our levels in line. Here are a few more. Anterior pituitary does an awful lot of jobs. These next two have a lot to do with our reproductive system, and they're called FSH, or follicle stimulating hormone, and LH, and luteinizing hormone. Follicle stimulating hormone in a female, because they're a little bit different for the boy and the girl. In a female, it stimulates the growth of what we call the follicle. So in your ovary, your eggs rest within little cell sacs called follicles, and these follicles mature over the course of a month. So follicle stimulating hormone stimulates the follicle to mature and also release hormones. That follicle can also release estrogen. So estrogen release is actually promoted by follicle stimulating hormone. In a male, follicle stimulating hormone causes the testes to produce sperm. And of course, there's a gonadotropin releasing hormone from the hypothalamus that controls both of their releases. So maturing the follicle and egg, and estrogen production in the female, and production of sperm in the male. Now luteinizing hormone, or LH, again different for the boy and the girl. In the female, it induces ovulation. Ovulation is when this follicle, which contains the egg, it matures over the course of a month, and around day 14, the egg will be ejected from the ovary so that it can be taken up by your fallopian tubes and then hopefully fertilized by a sperm. So that ovulation has to take place around the middle of the month, and ovulation takes place because of a release of luteinizing hormone. That's really important, but here's another really important thing. That follicle, this little egg sac of cells, that sac of cells, once the egg has been released, will degenerate into a gland, churn into a gland called the corpus luteum because of that luteinizing hormone. Here's the important part. The corpus luteum as a gland is the only source of progesterone. Progesterone is a very important hormone for the female because it helps us to maintain a pregnancy. It helps to ready the uterus for a pregnancy, producing all kinds of secretions within that uterine lining, especially that mucus plug that houses the embryo within the uterus for that 9 months. So a very important pregnancy hormone. So FSH also can help, LH also helps FSH in the production of estrogen. In fact, because not only can estrogen come from that follicle as it is maturing, but it also comes from the corpus luteum as well as progesterone. For a man, luteinizing hormone equally important because for a man it stimulates the testes to both develop and secrete testosterone from cells called interstitial cells of Leydig, which are found within that testes. There are all kinds of tubes in there, if you remember, called seminiferous tubules, and the seminiferous tubules are where the sperm is produced. In between that, there are interstitial cells of Leydig, where the testosterone is produced in response to luteinizing hormone being released. So for a boy, sometimes luteinizing hormone can also be called interstitial cell stimulating hormone, or ICSH, simply kind of a short for stimulating that area of the testes where the testosterone gets made. Again, luteinizing hormone is controlled by the release of gonadotropin releasing hormone from the hypothalamus. Thought we were done? Still not done, but this is the last one. So your anterior pituitary also will release one more hormone, and that's prolactin. Prolactin, or PRL, together with other hormones, helps to initiate and maintain milk production in the mammary glands or the breasts, and this generally takes place after the birth of a fetus. But here's the thing, prolactin is pretty straightforward. Prolactin promotes milk production. It does not promote milk release or letdown. Remember, that was oxytocin. But PRL works with oxytocin. PRL makes the milk, oxytocin releases the milk, and so together those are called lactation. We need progesterone too, because in the latter parts of pregnancy, progesterone actually will promote the doubling, tripling, even quadrupling in size of the mammary glands so that we can produce enough milk for that growing embryo or growing fetus. Now, most of the time we do not produce prolactin because most of the time we do not want to be producing milk. So we have an inhibiting factor called prolactin inhibiting factor that really kind of keeps that prolactin levels at bay. But once that child is delivered, prolactin releasing factor will really turn that PRL on. Can a man release PRL? Sure, he could. He shouldn't. It would be very abnormal. But for example, in a person with an anterior pituitary tumor, could he produce PRL? Could he secrete milk? Sure. There would come with an awful lot of other issues, but sure he could. Sure he could. Hey, we're moving on. So the next gland that we want to take a look at is your pineal gland. Now you learned this back in 2300 or your anatomy class. Again, this location right here is your hypothalamus. This location right here is your thalamus of your diencephalon. And this location right here is your epithalamus. Now your epithalamus, a portion of that, is called the pineal gland or the pineal body. And what's cool is the pineal gland or the pineal body releases a hormone called melatonin. Melatonin, interestingly, responds to light and dark cycles. You produce melatonin way more when it's dark, and what that does is it actually helps to induce sleep and actually gives you a better quality of sleep. It actually can help to put you in more of a stage 3 sleep and then into REM. Melatonin can also inhibit FSH and LH, and sometimes, if you've ever heard of a bunch of women living together, their menstrual cycles line up, it's usually because they're keeping the same clock, they're keeping the same schedule, light and dark, maybe the same work schedule, school schedule, going out and have fun schedule, and so their melatonin release would be on schedule, which would make their FSH and LH release be on schedule. And so, in fact, their menstrual cycles could eventually line up. The better sleep you get, don't you feel better? Don't you feel rested and happier? That's why melatonin has also been attributed to mood. Better sleep, better mood. The next gland that we want to mention is called your thyroid gland. And the thyroid gland, as you can see here, is kind of a butterfly shape or a two-lobed shape gland located on the anterior trachea in your neck. And that thyroid gland produces a hormone called thyroxine, also a hormone called calcitonin. Now, one of the things in your notes that I wanted to kind of go over and really explain is that this gland produces a hormone called thyroxine, has numbers of names because it can also be called thyroid hormone. It can also be called triiodothyronine or tetraiodothyronine because there are slight variations to the form of this hormone. And if you notice at the root of those words, triiodothyronine and tetraiodothyronine, iodine is at the root of those words because you actually need iodine to produce thyroid hormone or thyroxine. And that's actually why salt used to be iodized, to make sure that we had plenty of iodine to make thyroxine. You may see some pictures of people with goiter, which would be an incredibly enlarged thyroid gland, which can actually happen both if you are underproducing and overproducing thyroid hormone. But it's kind of common in underdeveloped countries where they may not have a good source of iodine. But back to the words. So thyroxine, or thyroid hormone, produced in the thyroid gland in response to TSH from your anterior pituitary, also in response to colder temperatures. This influences your metabolism, growth, development, and even the activity of your nervous system. So thyroid hormone, big deal, it affects your basal metabolic rate, which is how many calories you burn simply sitting still. Because what it does is it actually causes your body cells to burn more oxygen. Burns more oxygen in the presence of sugar, so we burn more sugar, which produces more body heat, and again, burning more calories. So the more thyroxine you have, the more calorie you burn, even sitting still. Interestingly, thyroxine also is very, very important during fetal development, helps to promote brain tissue development, nervous tissue development. Children who are born with very low thyroxine have a disorder called cretinism, when a very unusual cry, which usually alerts the medical professionals, which can be treated by giving thyroxine replacement. Usually in cold temperatures, high altitude, pregnancy, anytime we need to kind of alter our metabolism, that's when you actually may see thyroxine release. Interestingly though, a different hormone is calcitonin. Calcitonin is involved with your ability to maintain blood calcium levels, or the homeostasis of blood calcium levels. What calcitonin does is it actually lowers the amount of calcium in your blood. So that kind of seems bad, but it's actually a really good thing. What it's trying to do, so you don't ever have too much calcium in your blood, which could be bad, it actually will remove the amount of calcium that you have intaken by digestion, which that calcium would be taken into the bloodstream. Calcitonin can take that calcium and store it in your body's cells, specifically in your bone, and that can save it there for when we might need it. So it actually promotes the depositing of calcium in your bone. It prevents the breakdown of bone, and even promotes the uptake of calcium by your bones and even by your urinary system so you don't excrete too much out. We actually call this a bone-sparing chemical. It's really good for your bones because it's trying to deposit all that calcium in there all the time. So I wanted to go back a little bit and talk a little bit about this part right here of thyroxine. I wrote here at the end, aging may decrease its release. Sure, anybody over the age of 35 knows that they had to change their diet. And that's because we can't seem to eat as much as we could when we were 20 and still maintain our weight. And that's simply because as we do age, the amount of thyroxine or thyroid hormone that is released goes down. And so our metabolism goes down, and so our weight can go up. What are some other problems that you can think of with the thyroid gland? Did you say hypothyroidism and hyperthyroidism? You're right. You're absolutely right. Hypothyroidism would result from a decrease in thyroid hormone. And the reason could be lots of different issues. For example, you may have Hashimoto's disease, neck radiation, an autoimmune disease, damage to the thyroid gland. Any one of those could cause a lowering of the amount of thyroid hormone that would get released. You could also have lower thyroid hormone because you don't have enough TSH. Maybe your TRH is low. That would also cause a lowering of the amount of thyroid hormone. What happens when you have low thyroid hormone is you have a lowered metabolic rate. You may have what's called non-pitting edema, or real puffiness of the skin around the eyes, the hands, the feet. It's called myxedema. You may have an enlarged tongue, which is very common in that cretinism disease as well. And you're going to see a rapid weight gain. Obesity, lethargy, bradycardia means that you have a very slow heart rate. Things might slow down all over, so you may see constipation, decreased mental concentration, and even cold sensitivity. This is actually, unfortunately, a pretty common disorder. On the other hand, I used to think, hey, if I had to have a disorder, I'd like hyperthyroidism, and then my metabolism would be super strong. Well, that's not always exactly the case. With hypothyroidism, which we can call Graves' disease, the most common cause of hyperthyroidism, we can also call it toxic diffuse goiter. Interesting, like I said, this would be an increase in either the production of TH, thyroid hormone, or TSH, or even TRH. You would have increased metabolism, increased energy, but sadly what comes with that is you would have severe weight loss, tachycardia or a racing heart. You wouldn't be able to sleep and you'd be hyperactive. You may also suffer from diarrhea and something I certainly don't want, exophthalmia. Exophthalmia is when the eyelids retract and you actually form fat pads behind the eyes, so your eyes bulge out. I don't think I want that. You know, you can get a goiter or an enlarged thyroid in the neck from both hypothyroidism and hyperthyroidism. That's kind of an interesting fact. In fact, in some countries it can grow to 2, 3, and even 4 times its size. For me, I think we should all be happy if our thyroid gland works like it should. The next set of glands are called the parathyroids because they're located on the thyroid. This picture that we saw of the thyroid, let's go back up 1, 2, here. Let's turn it around. You're looking at an anterior view here, and here's a posterior view of the same picture. So here's the thyroid lobe and the thyroid lobe. Here are 2 parathyroid glands on either side. So you have 4 tiny little parathyroid glands on either side of that posterior thyroid. The most important thing that this little guy does is produce a hormone called PTH, or parathyroid hormone. This has the biggest or the greatest role in regulating those blood calcium levels, but it goes in the opposite effect of calcitonin. Whereas calcitonin lowered your blood calcium, PTH wants to raise your blood calcium. Maybe you need calcium in your blood to affect your muscles, to allow you to release neurotransmitters. Very important, calcium, for muscles and nerves. So if you need to raise your calcium, PTH to the rescue. It can activate your vitamin D. It can increase the rate of calcium absorption from your GI tract, but it can also promote bone breakdown by your osteoclast so that you release all that calcium that you had stored in your bone. So your body knows that calcium is really important to muscles and nerves, and it would steal it from bone if it had to. And parathyroid is the hormone that makes it do that. It can also target your urinary system to promote reabsorption of calcium from the urinary system as well. So if your blood calcium is low, we would actually call this a bone-destroying hormone because it's going to target your bones to release that calcium that we need to run our nerves and our muscles. So you can see on the right here a picture of osteoporotic bone, which is really common, in fact, in older women, postmenopausal women, because postmenopausal women see a lower amount of estrogen. Lowered estrogen prevents the reabsorption of calcium from the digestive tract. You actually need estrogen to absorb the calcium that you drink in your milk. So without that estrogen, you can't absorb the calcium. And without that absorbed calcium, PTH to the rescue, they'll go to your bone and steal it from bone in order to supply your muscles and your nerves. That's why osteoporosis in postmenopausal women is so common. Let's take a look at the two small glands that sit on top of your kidneys. Those are called adrenal glands, adrenal, on top of the kidney. They're going to produce two kinds of hormones, the catecholamine hormones, norepinephrine and epinephrine, as well as your steroid hormones. Because you can see there's an outer layer of the adrenal gland called the cortex, and there's an inner layer called the medulla. And each of those layers secrete different kinds of hormones. Let's look at the cortex first. This cortical layer of the adrenal gland produces your steroid hormones. So the steroid hormones we're going to take a look at are aldosterone and cortisol. Aldosterone acts on cells in the kidney to increase their reabsorption of sodium from the urine and return it to blood. We know how important sodium is. Think of your sodium ion channels. Think of muscular contraction, neurotransmitter release across the synapse, the action potential alone. Very important. So maintaining our sodium levels, critical to life. So we may have to reabsorb more sodium from the urinary tract so that we don't lose too much, or we may have to let more go, and aldosterone is the key here. Aldosterone can promote the reabsorption of sodium, and at the same time, it would then release potassium, because they're always released in opposition to each other. If you promote potassium reabsorption, then you would lose more sodium. But aldosterone's job is to increase sodium in the blood, so pulling it from the urine. It also's job is to decrease the amount of potassium in the blood. Too much potassium could spell disaster. Aldosterone, because of its increase in sodium, can also have an effect on your blood pressure. Can you imagine if it would go up or down because of aldosterone release? I hope you said up. That's right. The more sodium you have in your blood, the higher potentially your blood pressure can be. This is just a nice slide again, a little busy, but I want you to take a look at it when you've got some time, because there are different reasons why aldosterone could be released. And a lot of reasons kind of all fall back on maintaining your blood volume and maintaining your blood pressure. What if you have lost too much water? Or what if you don't drink enough water? Having more sodium in your blood increases osmolarity, which would keep more water from being lost in the kidneys. The higher the osmolarity, the more the water retention. And so having more sodium could actually cause you to retain more water. Aldosterone can help with that. If you had low blood pressure, we could retain more sodium, which would cause us to retain more water, which would increase blood volume, which would increase your blood pressure. And so aldosterone can be used in both cases to simply maintain our blood volume, increasing the water value, or increasing the blood pressure by again affecting water. So the amount of sodium is really, really critical in the release of aldosterone by maintaining that sodium reabsorption, really critical. So I wanted you to see this slide and just see all the different ways that it's possible. And we're going to talk a lot about this when we do the urinary system, all the ways that it's possible for aldosterone to have that effect. And then we're eventually going to talk about this renin-angiotensin system and atrial natriuretic peptide and how they kind of try to either turn on aldosterone release or turn it off. Another hormone that is released by the adrenal cortex is called cortisol. And cortisol is released in response to two things: a stress on the body and ACTH from the from the anterior pituitary gland. What cortisol does really helps us to withstand stressors, stressful situations, traumas to the body. What cortisol will do, you have to think of it this way. This is the body saying, I need to protect myself because I am under duress. And if you think of it that way, what cortisol does to raise your blood glucose level, make sure you have enough food. Suppress the immune system. Make sure those white blood cells don't attack. It definitely suppresses your inflammatory response. Cortisol can decrease our sensitivity to pain. Cortisol can increase our blood pressure. And in fact, it can actually increase our memory and attention. Cortisol can also have a direct effect on our metabolism. What it can also do is what's called increases protein catabolism or protein breakdown. So if you don't have enough sugar to feed that body, cortisol can break down your protein, and that will be converted into glucose so that we can use it for energy. So it can also cause muscle wasting if there's too much cortisol. Something like Cushing's disease would be something to look up. Too much cortisol, you see protein wasting, and you actually see extremely high blood sugars. So a person maybe who has too much cortisol, or how about too much stress, can see really high blood sugar, protein wasting, and a lot of fat deposition in the gut. How does this hormone affect wound healing? Anybody ever had a damaged joint, for example? You can get a cortisone injection, which is cortisol. Because of its ability to interfere with wound healing, to suppress the immune system, it actually turns off inflammation, which turns off inflammation to that damaged joint, for example, which allows it to heal and undergo kind of relieving therapy during that time. With too much inflammation, sometimes even physical therapy could cause harm. Let's remove the inflammation first, and then we can do all of our stretches, which will really take effect. Now, if we take a look at our adrenal gland, we took a look at that outer cortex with cortisol and aldosterone, steroid hormones, but now let's take a look at that medulla, that center core, and the hormones that are released here are our catecholamine hormones, epinephrine and norepinephrine. Epinephrine and norepinephrine, remember these used to be called adrenaline and noradrenaline. They can act as hormones as well, also helping us to respond to stressors. They also activate, because they are epinephrine, they activate the sympathetic nervous system. They still bind to alpha and beta receptors, and they still prepare the body for fight or flight. They can increase your heart rate. They increase your pulmonary ventilation or breathing, still dilating the pupil. They'll increase your blood sugar levels. Again, though, this is a response to stress. Same thing we saw with cortisol. It'll inhibit your gastrointestinal tract mobility. It increases blood flow to your skeletal muscles, that vasodilation effect which we saw, and increases the strength of contraction. It's still a response to a stressor on the body and a way for us to help to kind of prepare the body for what trauma may come. So cortisol and epinephrine actually work together. I like to think of cortisol as being more of a long-term stress response, And I like to think of our epinephrine as being more of a short-term response to stress. And so from this slide, you can see that epinephrine, again, increases your heart rate, your blood pressure. It helps us to increase our blood sugar levels, helps us to breathe easier, and ultimately does change our blood flow, vasodilation to the skeletal muscles, vasoconstriction to the core. Whereas cortisol, retention of sodium, cortisol, that was aldosterone. Cortisol, protein and fat can be converted into glucose. That's that muscle wasting potentially, protein breakdown and protein catabolism. It can increase our blood sugar and suppress our immune system, all as a response to a long-term stressor. Now we move on to the pancreas. The pancreas is both an endocrine gland and an endocrine organ, meaning that it has dual roles. As an endocrine gland, it can release hormones, but as an endocrine organ, that means there's something else that the pancreas can do. One of the other things that the pancreas can do is act as an exocrine gland. That exocrine portion actually promotes the production of digestive enzymes and bicarbonate, so we can use that in the digestive system. It's a really unusual little organ. It's a gland organ that's located just behind and below your stomach. If you take a look at this picture of the pancreas, we've just pulled out some cells so we can see the different kinds of cells that are found inside your pancreas. There are what are called acinar cells, and acinar cells are actually those cells that produce the digestive enzymes and the bicarbonate, so we can digest fats and proteins and carbohydrates in the food that we eat. But there's also a patch of cells that are called alpha cells, beta cells, delta, and F cells. These particular clusters are able to produce the two hormones we want to talk about. From the alpha cells, we release glucagon, and from the beta cells, we release insulin. Insulin, we'll talk about it first. Both of them regulate the amount of sugar or glucose that we have in our bloodstream. Insulin's job is to increase, Insulin's job is in response to an increase in the amount of sugar in your blood. Let's say you just ate a candy bar, and all of that sugar is now in your bloodstream. Well, we can't have our amount of sugar in our bloodstream get too high because that irritates the blood vessels. And so insulin has to swoop in, and it helps by lowering that glucose. What it does is it stimulates glucose movement from your blood into your body cells, like your liver and your muscles, so it can be stored there and used when needed. So what it's doing, ultimately, that insulin, it takes all the sugar from your blood, a lot of the sugar from your blood, and promotes that to be stored, glucose into glycogen in your liver, stored in your tissues. It's removing it from your blood and lowering the amount of sugar in your blood, and that's a good thing. But you don't want it to be too low. Glucose is necessary for normal energy production, especially in our brain. And so what if you're one of those people that doesn't eat breakfast, and you try and come to class and pay attention, and your blood sugar levels are starting to get way too low? What should you do? Well, your pancreas will take care of you. Your pancreas will produce a hormone called glucagon. Glucagon is released in response to a very low blood sugar. What can happen is the pancreas releases glucagon, which will go to the liver or other body cells, and it will actually promote the conversion of glycogen into glucose. Glycogen into glucose. This is called glycogenolysis. And that glucose can then be released to raise the amount of sugar in your blood and promote the production of energy. So there's a couple of other things that it can do. It can actually undergo what's called gluconeogenesis as well. So sometimes, even if we don't have enough glycogen to fuel our body with sugar, we can also convert proteins like amino acids fats, they're monoglycerides, we can convert those molecules into sugar so that we can increase the amount of sugar in our blood. And glucagon can do that as well. It's just called gluconeogenesis, when we convert amino acids into sugar, or lactic acid into sugar, or fatty acids into sugar. But if we have plenty of sugar stored, maybe we ate lasagna yesterday and lots of sugar got stored in our body cells and in our liver, all of that sugar can be converted from its storage molecule called glycogen into glucose and then be released. So that's simply called glycogenolysis. So you're protected either way, whether you eat or whether you don't, by either insulin when you eat or glucagon when you don't. Uh-oh, what happens if you can't control the amount of sugar in your bloodstream? Well, that is a very common disorder that we probably all know to be diabetes mellitus. Diabetes mellitus is an insulin-related disorder of glucose metabolism, where you see things like hyperglycemia. Hyperglycemia means too much sugar in the bloodstream. You also see problems with lipid metabolism. What's ultimately going to happen is if we can't process sugar, we're going to process fat instead. And so you may see lipid metabolism kind of on the uprise. And so we see high productions of triglycerides, high deposits of cholesterol plaques because of this problem with being able to really use our sugar. The problem with diabetes mellitus is we cannot either use our insulin or we don't have any insulin to use. So a lack of insulin, very common in type 1, or what we call insulin insensitive in type 2. Let me explain that better. So in type 1, we often will see this as a destruction of the beta cells which produce insulin. A lot of times this is an autoimmune response, an autoimmune disease, and this usually occurs in a younger person. This is why it's usually called juvenile onset. A person who has destruction of the beta cells would not make insulin. If they cannot make insulin, they must be insulin dependent because their blood sugar would be simply too high. And so we usually call this IDDM, or insulin dependent diabetes mellitus. A type 2, which is what we're rapidly seeing the onset in this country, huge numbers of people developing type 2, this is due to what we call insulin insensitivity, or a resistance to the insulin that you are making but your body is not responding to. We usually begin with not taking an insulin replacement and just taking a medication that lowers the amount of sugar in our blood. So that's usually why type 2 is called non-insulin dependent, though usually after a while insulin injections would still be a way to treat this disorder. It also used to be called adult onset because this was much more common in older adults, obese adults, but now we're starting to see it in children. Here's the problem, and this is how I usually try to explain diabetes. The problem is sugar in our bloodstream. While we need that sugar, we definitely do. When you have too much, it irritates your blood vessels. It's like wearing a wool sweater all day long, and you're like, get this thing off of me. Well, imagine that wool sweater irritating your blood vessels constantly. Eventually your blood vessels are like, I have to do something to protect myself. And so your blood vessels start to thicken. When they thicken, the actual lumen, the amount of blood that can go through, is sometimes cut very short. And so you see injury, lack of blood supply to the eyes. That's called diabetic retinopathy, or blindness. You see damage in the peripheral arteries, coronary artery disease, cerebral vascular disease, lightheadedness, fainting, stroke, tiny strokes. They're called TIAs, transient ischemic attacks. When we can't process this sugar, we still need energy. And so you're going to see increases in depositing and usage of fat sources. And so atherosclerosis may actually occur at a younger age. You're going to see increased levels of triglycerides and cholesterols. If we go back to our blood vessels continuing to narrow, you're going to see difficulties with the kidneys called diabetic nephropathy, and where we actually will lose renal function. This takes place over long periods of time when you do not manage your sugar. Urinary tract infections because of too much sugar in that urine. Your nerves become damaged as we lose those blood vessels. This is called diabetic neuropathy. Diminished sensation in the legs, feet, hands, impotence in the reproductive structures, pains in the calves, thighs, buttocks. This can be severe pain requiring pain management. You'll see skin lesions because you can no longer feel any cuts or damage, and you have poor blood flow. You'll also have many difficulties with the gastrointestinal tract. One of the problems with diabetes mellitus is that you simply cannot process your sugar, usually because we have abused that ability. If we eat too much sugar, we release too much insulin, and then eventually the body says, enough, I'm not responding to you anymore, and you become insulin insensitive. And that's why we do see that very often if a person who is older, who is very overweight, loses the weight and kind of tries to improve their cardiovascular health, their symptoms of diabetes can often diminish significantly and even go away. This is one of those disorders that diet and exercise can truly control. We're going to finish up finally, and I know this has been a long one for you, we're going to finish up finally with a discussion of reproductive structures. We're going to take a look at your ovaries and your testes, also both endocrine organs. So they have endocrine gland function as well as other functions as well. To begin with the ovaries, you can see we have the uterus here in the center. We have two paired ovaries on either side. These ovaries can produce two hormones, estrogen and progesterone. And interestingly, we've kind of already talked about this because we talked about follicle stimulating hormone and luteinizing hormone. So we're really going to just revisit. But estrogen, we mentioned, is produced by that follicle inside the ovary that houses the egg. That follicle produces estrogen as it matures, and then once it is converted to the corpus luteum by luteinizing hormone, it can also continue to produce estrogen. Here's something that you may not have known. Where does estrogen come from before those ovaries develop, before puberty? Well, some estrogen can come from the adrenal cortex, that center for steroid hormones. It also produces quite a bit in your fat cells. So the more fat cells we have, the more estrogen we actually often can see, which is an interesting symptom sometimes when we do gain a lot of weight. Estrogen stimulates the maturation of female reproductive tract, the female reproductive system. It also stimulates fat deposition in the subcutaneous layer of skin. So the reason that the females have a nice curve or a nice form, breasts, hips, butts, is because of estrogen. If you want bigger breasts, estrogen will do it. It's also the primary sex hormone during the proliferative phase of the menstrual cycle. So your menstrual cycle, the female menstrual cycle, is based on like 28 days, and it is a time when the eggs within that ovary will mature, get released, and then hopefully settle in the uterus to house and nourish a growing embryo. So that's the whole idea. And so there are phases of this menstrual cycle that we will eventually get to talk about. So the whole beginning of your cycle is called proliferative phase. It's when we're really trying to ready the uterus. And estrogen is important for that first step. Progesterone is also produced within that ovary, but most specifically within the corpus luteum. Remember, the corpus luteum used to be the follicle, but after ovulation will change into a gland called the corpus luteum, which produces primarily progesterone and a little bit of estrogen. Progesterone stimulates the formation of your lactiferous glands within the breast. It can also increase the size of those glands after a baby has been born. It inhibits myometrial contractions. That means that your uterus won't contract so that you can house an embryo and allow it to maintain a pregnancy for 9 months. It also increases what's called the vascular supply to the inner lining of the uterus, so we can feed that embryo at least for the first 3 months until the amniotic sac can be completed. It's also a really important hormone for the second phase, called the secretory phase of the menstrual cycle, where we continue to ready that uterus for hopefully the fertilized egg. Our last hormone is an androgen. This would be a male steroid hormone. And what you're looking at is a picture of the testes. And within the testes, remember we have the seminiferous tubules where the sperm are produced in response to FSH. But we also have the tissue in between. In between are the interstitial cells of Leydig. And in the interstitial cells of Leydig is where we produce testosterone, the male androgen. Interestingly, again, just the same way with a female, where did testosterone come from before puberty, before the testes developed? It also came from the adrenal cortex. So testosterone is the primary male androgen, the primary male steroid hormone, and it's definitely needed for the formation of the male reproductive system, the secondary sexual characteristics, the deepening of the voice, the maturation of the testes, the formation of larger muscles, sometimes aggressive behavior, all comes from testosterone. I believe that ends our topic of the endocrine glands. There's quite a few glands to know, and what I would definitely recommend is kind of preparing a little chart for yourself where you may have the gland on the left and maybe the different hormone on the right and maybe a function for yourself to practice with. And in fact, if you look on your notes, on the page where our notes are, on our Blackboard site, I have a little chart already ready for you to fill in, just as practice. The more you can practice with this system, the much better off you'll be. And I hope you to ask me questions if you have any as they arise.